Hi, today I'm going to talk about the innervation and blood supply of the heart. We'll discuss the origin and distribution of the coronary arteries, the concept of the arterial dominance. We'll look at the localization and distribution of the components of the conducting system of the heart, and we'll talk a little bit about the composition of the extrinsic cardiac plexuses. We'll start from the blood supply of the heart. The heart supplies with blood all our body. It never rests or takes breaks, and myocardium needs a proper blood supply itself to support its function. The two coronary arteries provide the perfectly oxygenated blood to the heart itself. They branch off from the ascending aorta just above the right and left semilunar aortic valves. Anytime the valves close to prevent the backflow of the blood, the openings of the right and left coronary arteries are widely open, and richly oxygenated blood rushes into them, supplying the heart. We literally have the cardiac circulation here, running parallel with the pulmonary and systemic ones. Such a perfectly organized system. Now let's review the localization and branching pattern of the coronary vessels. As you remember, we have a circular coronary sulcus that runs between the atria above and ventricles below, and two descending to the apex interventricular grooves, the anterior and posterior one. These grooves have their purpose here. They house the cardiac vessels. Thus, the right coronary artery runs to the right in the coronary sulcus, and the left coronary artery has a very short trunk that branches into two: the anterior interventricular artery, which occupies the anterior interventricular groove, and the circumflex artery, which runs left in the coronary groove to meet the right coronary artery on the posterior surface of the heart. And the posterior interventricular sulcus houses the posterior interventricular artery, which may be a continuation of the right or left coronary artery, determining the dominance of cardiac blood supply. Other variations, such as presence of an accessory third coronary artery or doubled posterior interventricular artery from both sources, may also occur. The branching pattern of the coronary arteries is a subject of variability, as you see, but the most commonly appearing branches may be often identified. For the right coronary artery, these branches are the posterior interventricular, right marginal, atrial branches, including the sinoatrial nodal branch and the atrioventricular nodal branch. The left coronary artery branches off the anterior interventricular artery or left anterior descending LAD, and it gives some lateral diagonal branches to the wall of the left ventricle. And it gives the circumflex artery that branches off the left marginal branches and some innominate branches to the left ventricle and continues to the posterior surface of the heart. The atrioventricular nodal branch may branch off from any of the coronary arteries, and it is the one which determines the right or left dominance of the coronary blood supply. The vessel supplies the atrioventricular node, and if it is obstructed, the contraction of the ventricles may be compromised. So it is clinically important to know which coronary artery, right or left, feeds the atrioventricular node. Now let's summarize the areas of distribution of the right and left coronary arteries. The right coronary artery supplies the right atrium via its atrial branches. It also supplies most of the right ventricle via the right marginal and several innominate branches. It supplies part of the left ventricle on the diaphragmatic surface of the heart via the posterior descending artery and its branches, and part of the interventricular septum, usually the posterior third of it, by posterior descending artery. Additionally, it often gives branches to the sinoatrial and atrioventricular nodes, the sinoatrial and atrioventricular branches, correspondingly, in case of the right dominance of the heart. The left coronary artery supplies the left atrium. We have some atrial branches here, most of the left ventricle, while the anterior descending and diagonal branches and the left marginal branch is here too. Part of the right ventricle, if the posterior descending branch is a continuation of the circumflex artery, and additionally it supplies most of the interventricular septum, including the AV bundle, giving off the perforating branches to it. And in 40% of cases it supplies the AV node, if the posterior descending branch is a continuation of the circumflex artery, in case if we have the left dominance of the heart. The terminal branches of the right and left coronary arteries, they anastomose with each other in about 10% of individuals. The circumflex branch of the left coronary artery may anastomose with the terminal branches of the right coronary arteries. The anterior interventricular artery may anastomose with the posterior interventricular artery at the apex of the heart. And these anastomoses are important in case of obstruction of the main branches, as they provide the bypass routes for the blood. In slow occlusion of a coronary artery, the collateral circulation has time to increase so that adequate perfusion of the myocardium can occur in case of a potentially ischemic event. Consequently, myocardial infarction may not result. On sudden blockage of a large coronary branch, some infarction is probably inevitable, but the extent of the area damaged depends on the degree of development of the collateral anastomosis. Clinical studies show that anastomosis cannot provide collateral routes quickly enough to prevent the effects of sudden coronary artery occlusion. The functional value of this anastomosis thus appears to be more effective in slowly progressive coronary artery disease and in individuals that are physically active. And what is the coronary artery disease we are talking about? Coronary artery disease is one of the leading causes of death. It has many causes, all of which result in a reduced blood supply to the vital myocardial tissue. The atherosclerotic process is the most common cause of coronary artery disease. It is characterized by lipid deposits in the intima, in a layer of the coronary arteries. It begins during early adulthood and slowly results in stenosis of the lumina of the arteries. Partial narrowing of the one or another coronary artery leads to an ischemic heart disease, that is a chronic coronary artery insufficiency, which may be timely diagnosed and treated. Otherwise, a full blockage of a coronary artery occurs, which results in a heart attack or myocardial infarction. The area of heart muscle that is supplied by the blocked artery will die if blood flow is not reestablished within 20-40 minutes. The three most common sites of coronary artery occlusion and the percentage of occlusions involving each artery are, first of all, the anterior interventricular branch of the left coronary artery, up to 50% of cases, the right coronary artery in 30 to 40% of cases, circumflex branch of the left coronary artery in up to 20% of cases, and the circumflex branch of the left coronary artery in 15 to 20%. The earliest symptoms of the coronary artery disease are the angina pectoralis and specifically referred pain. Pain that originates in the heart is called angina or angina pectoralis. Individuals with angina commonly describe from 15 seconds to 15 minutes episodes of constricting pain as tightness in the thorax, deep to the sternum. What is the mechanism of this pain? The reduced blood flow results in less oxygen being delivered to the cardiac striated muscle cells. As a result of the limited anaerobic metabolism of the myocytes, lactic acid accumulates and the pH is reduced in affected areas of the heart. Pain receptors in muscle are stimulated only by lactic acid. Heart is insensitive to other irritations such as touch, vibration, cold, and heat. The cardiac visceral sensory pain fibers follow the middle and inferior cardiac splanchnic nerves, which are sympathetic in nature, and are sent back to the spinal cord. The cell bodies of these nerve fibers are located in the dorsal root ganglia. The axons of these cells enter the spinal cord at the level T1 through T4 or T5 and synapse on the neurons in the dorsal horns of the spinal cord. The medial cutaneous nerves of the arm and forearm, as well as the second and third intercostal nerves, which give off the intercostal brachial nerves, all have their synaptic connections at this level of the spinal cord. That's why the cardiac pain is commonly felt as radiating from the substernal and left pectoral regions to the left shoulder and the medial aspect of the left upper limb. Such angina provides a warning that the coronary arteries are compromised and that there is a need for a change of lifestyle, healthcare intervention, or probably both. At this stage, it is a good idea to check how passable the coronary arteries are and now look at their branches. A coronary angiogram is a procedure that uses X-ray imaging to see your heart's blood vessels. Coronary angiograms are part of a general group of procedures known as heart catheterization. This video demonstrates the procedure. The right radial artery is used to approach the aorta. Following the arterial puncture, the catheter is advanced through the brachial, subclavian, and brachiocephalic arteries to the ascending part of the aorta. Then the catheter is directed to the aortic valve cusps in order to find the opening of the coronary artery and inject the contrast material into the lumen of the coronary artery. First, the left coronary artery gets injected, and you can see your LAD and the circumflex arteries on the X-ray screen. We even can differentiate and evaluate the diagonal and marginal branches of the left coronary artery. Then the catheter is repositioned towards the inlet of the right coronary artery, and we see the extent of this vessel, which has, by the way, much less branches than the left coronary artery. If any of the branches is occluded, it will appear like this. The minimally invasive transluminal coronary angioplasty may be performed in selected patients, in which they pass a catheter with a small inflatable balloon attached to its tip into the obstructed coronary artery. When the catheter reaches the obstruction, the balloon is inflated, flattening the atherosclerotic plug against the vessel's wall. The vessel is stretched to increase the size of the lumen, thus improving the blood flow. Or, as an alternative, an intravascular stent may be introduced to maintain the dilation of the vessel. Patients with contraindications to the first non-invasive method of reconstruction undergo to open surgical procedure called coronary bypass graft. In this case, a segment of an artery or vein is connected to the ascending aorta or to the proximal part of a coronary artery, and then to the coronary artery distal to the stenosis. The great saphenous vein is commonly used for coronary bypass surgery because it has a diameter equal or even greater than that of the coronary arteries. It can be easily dissected from the lower limb and offers relatively lengthy portion with a minimum occurrence of valves and branches. To complete the picture, we need to add the veins we have on the surface of the heart. And it's easier to memorize them in pairs with the arteries they run with. Thus, the anterior descending artery is accompanied by the greater cardiac vein. The posterior interventricular artery runs parallel with the middle cardiac vein. The right coronary artery in the coronary groove is accompanied with the small cardiac vein. Additionally, we have several small cardiac veins draining the atria and ventricles. All these veins, they enter the coronary sinus, a wide venous channel that runs from the left to the right on the posterior part of the coronary sulcus. The last one opens into the right atrium of the heart. We have an opening of the coronary sinus with a valve here, you may remember.